to risk stratify these patients and identify high-risk patients. There is no doubt that the cardiac MRI has role. The increase in scar, which was shown by Saman Nazarian when he was in Johns Hopkins, there is no doubt if the cardiac MRI identifies scar and there is increase in scar burden, which is seen with MRI, there is increased risk of arrhythmia and ventricular tachycardia in these patients. Especially in certain subset of populations, of certain subset of different types of non-ischemic cardiomyopathy. This was work we did at Penn, where we looked in patients with cardiac sarcoid. In left, we have this 16-segment bullseye left ventricular model, where the dark represents areas of scar. And as we can see, that corroborated well with other modalities such as PET and also with bipolar voltage map. And therefore, in cardiac sarcoidosis, MRI may be an excellent tool to identify scar and may be utilized as something which should be utilized for risk stratification. This may not be true for every other case. Patients with RV cardiomyopathy, the correlation of MRI picking up scar is really poor when compared to the electroanatomical map. Here we have scatter correlation plot where in the y-axis we have electroanatomical map showing scar burden for left ventricle and right ventricle. On the x-axis we have MRI scar burden for left and right ventricle. And as we can see, there is practically no correlation which can be seen. So while in sarcoid we see an excellent correlation, that might not be the case in all the other different non-ischemic cardiomyopathy. And therefore, cardiac MRI might not be the only investigation which should be utilized, but should be one of the tests which should be done. Electroanatomical map, again, has been shown to be quite, in fact, very sensitive in picking up scar, and that has been correlated with arrhythmia burden and inducibility of ventricular tachycardia. Here we show unipolar and bipolar voltage map. Again, as we were looking at these maps before, the purple is good tissue, healthy tissue, and as we go to the red and yellow, those are the areas of scar. As we can see, the unipolar represents a broader antenna, means mid-myocardial and epicardial scar, whereas bipolar voltage is more localized tissue. And we see the more scar burden we have as identified by electroanatomical mapping, it was associated with increased burden of ventricular tachycardia. So therefore, electroanatomical map and use for scar burden assessment can be a good tool to try and risk stratify these patients. So I'd like to present a case which will try and highlight the issues regarding this. This case was recently done. We had a 24-year-old young girl who had flu-like symptoms, who initially presented to emergency department with feeling short of breath. An echocardiogram was done, which shows an EF of 24%. She was started on optimal heart failure medication, and 3 months later, she comes with an ejection fraction of 55%. 6 months later, we were all happy that, okay, the LV function has improved. She was discharged. 6 months later, she presents to emergency department again with palpitation and a ventricular tachycardia. We have a left bundle V4 transition inferior axis consistent with tachycardia coming from right ventricular outflow tract region. Echocardiogram at this stage showed a completely normal left ventricle with a normal valves, normal relaxation and everything. The MRI scan was done and completely normal MRI with late gadolinium enhancement showing no evidence of scar whatsoever. This patient was taken into the lab. We had 8 different types of ventricular tachycardia, either induced or spontaneous, going on in this young 24-year-old. Extensive voltage mapping was done, and this again shows voltage mapping of bipolar voltage, which looks at the shorter antenna or local tissue, and a unipolar map, which looks at a broader spectrum. That means mid-myocardial and epicardial or outside the heart. We see a little bit of disease around the right ventricular outflow tract region. So this is outflow, free wall and outflow tract. This is outflow, and this is the free wall, and the septum is on this side. So we definitely saw disease process in the bipolar. However, we saw quite extensive disease in the unipolar, suggesting that the disease process is more epicardial than endocardial, it's outside the heart. We therefore went epicardial, and what we found, which surprised us, was there was an extensive amount of scarring which was seen in the epicardium. A lot of areas with fractionated potentials and late potentials, all suggestive of scar and disease process in the epicardium of this patient, where MRI showed a completely normal right ventricle. After that, we did a substrate modification. We ablated around this area and got rid of all those different 7, 8 different VT this patient was having. At the end of the procedure, we could not induce any more further VT. We did a drug challenge test, and it was not inducible. 2 days later, this patient again went back to have a drug stimulation study along with the ventricular VT stimulation, and we could not induce a tachycardia. Patient refused ICD, saying, I'm treated, I'm cured, I want to go home. I don't want an ICD to live with whole life. I was nervous. We got this patient back after 3 months, trying to repeat that, just trying to convince myself, to convince patients, say, no, actually you still have. And I was almost praying that she should have some type of ventricular tachycardia so that we can offer her device. We could not induce, and she still refused an ICD. I'm not sure what should be the right advice in this patient. However, this does highlight that if we have a newly diagnosed non-ischemic cardiomyopathy patient comes, we need to start thinking about risk stratification. Utilize different modalities which we do currently have. Use mapping technology, think of biopsy, cardiac MRI, using ECG, signal average, or T-wave to try and identify those patients who are at greater risk. Based on those, we might be able to categorize these patients into high risk if they have electroanatomical changes on mapping, or biopsy showing extensive changes, or a cardiac MRI showing scar, or ECG changes which might suggest. Or a low risk if none of these things are present. We'll be very lucky because if these patients fall in any of these two, if you are at a high risk based on the stratification and your LV function is low, there is no doubt you need an ICD. Or if you are low risk and your LV function has normalized, again, there is no confusion, and we will not put any ICD in these patients. We're still not sure what should be done in scenario 1. When you are a high-risk patient, based on the risk stratification, but your LV function has normalized. There is a question whether there is the patient still remain at a high risk of sudden cardiac death in the future. That's number 1. Number 2, should we wait for 3 months in these patients? Or should we implant an ICD in these patients anyway and not wait for 3 months because they are at high risk anyway? Maybe these patients, in spite of having a normal LV function, will still require an ICD. And the last group is where the LV function has improved, has remained low, but there is low risk. There is no scar we have seen. There is no significant voltage abnormalities are the things seen. The question remains, is that 3 months cutoff we have at the moment for optimal heart failure medication based on any data? There is very sparse data based on which this recommendation is. Should we wait for 4, 5, 6 months in these patients rather than just at a 3-month mark, we decide, okay, you are for an ICD? Or ICD may not be needed in these patients if you wait for, say, 4 or 5 months and LV function has improved in that. So I'd like to conclude here by saying, ladies and gentlemen, the sudden cardiac death risk stratification in non-ischemic cardiomyopathy population is challenging. Complex etiology of sudden cardiac death in non-ischemic population demands we trying to develop a better risk stratification tool. Non-ischemic subgroups, like having a low risk of sudden cardiac death or high risk of sudden cardiac death, is important. We need to try and identify these patients. However, it's important to realize the competing risk of death from other causes, which has to be considered, like multiple other comorbidities, renal failure, malignancy in these patients they might be having. Prospective studies that test various algorithms of risk along with timing and frequency of this assessment is required. I'd like to conclude here and I'll open for question. Thank you.